Welcome to the deep dive. We are jumping straight into a fascinating stack of source material you've shared with us today. Specifically, we have a detailed guideline document here that lays out a really significant initiative in India.
That's right. This document, it focuses on the national plan for implementing telemedicine services, particularly how it's envisioned to unfold within India's Ayushman Bharat Health and Wellness Centers, the HWCs.
LRCs, right.
It's pretty comprehensive. A blueprint covering strategy, setup, tech, the nuts and bolts required on the ground.
And our mission in this deep dive is to really explore this document you've given us. We want to understand the core vision driving it, get a clearer picture of how it proposes to bridge some, well, significant healthcare gaps, and really pull out the key components and the challenges too, right? Because it's such a large-scale thing.
Exactly. It's not just about rolling out some new software.
No, it's about a massive country planning to bring essential healthcare closer to millions using these digital tools.
It's aimed at a fundamental transformation of, well, primary healthcare access.
Okay, let's start where the document starts then, setting the stage. It highlights this core problem. India's seen remarkable economic growth, which is fantastic, of course. But the progress in health hasn't quite kept pace proportionally. While there have been gains, life expectancy, mortality rates, the source indicates they still fall a bit short of national and global targets.
And what's particularly insightful in the document is how it really pinpoints the specific challenges holding back that health progress, especially, like you said, in rural areas.
Right.
It clearly identifies that access to and fulfillment of healthcare needs are inadequate there. And the core problem isn't just a scarcity of doctors overall, but their, let's say, significant geographic maldistribution.
So the expertise is concentrated elsewhere.
Precisely. It's often bottlenecked in cities and tertiary centers. So it's just hard to access where it's needed most out in the villages.
So you might have a basic clinic nearby, but the actual doctors, the specialists, they aren't consistently available locally.
Exactly. And that's coupled with, well, inadequate capacities among the existing primary level providers, at the PHCs, the HWCs. There's often a lack of an organized continuum of care between different levels.
Right.
And even issues with consistent drug prescription and dispensing in these remote areas.
So think about this from your perspective as the listener. Imagine needing advice from, say, a cardiologist or a pediatrician for your family, but you live miles from the nearest city hospital. Getting that specialist consultation, it probably means a long, maybe expensive, often just impossible journey.
Yeah.
It sounds like this document really frames technology, specifically telemedicine, as a potential answer to this critical gap, this geographic and resource gap.
That's exactly the strategic thinking laid out here, and this is where the Ayushman Bharat initiative comes in. The document points out that the national focus on transforming existing primary health centers, the sub-centers, into these health and wellness centers provides a really crucial foundation.
It's not just changing a sign on the building, is it?
Not at all. It's about expanding the whole scope of services offered and strategically using information technology, IT, to address these systemic issues holistically.
And the source is very clear, isn't it, on the specific problems this telemedicine solution is meant to tackle head on. It lists things like the non-availability of doctors and specialists at the ground level, the high burden on district and tertiary hospitals because the primary level can't handle certain cases. The document calls it a lack of gatekeeping.
Right, no filter.
Plus the current lack of systematic health record creation and that kind of disjointed care continuum you mentioned between facilities.
Which brings us nicely to the solution framework presented in these guidelines, designed to address exactly those challenges.
Right. So the Ayushman Bharat commitment mentioned in the source was, well, pretty ambitious. Transforming 1.5 lakh, that's 150,000 sub-health centers and primary health centers, into HWCs by December 2022.
And that transformation, it involves significantly expanding the scope of care, moving beyond just, the selective programs like RCH or infectious diseases.
The traditional focus.
Exactly. HWCs are envisioned to provide comprehensive primary care. That includes screening and management of NCDs, non-communicable diseases.
Like diabetes, hypertension.
Right. Basic mental health care, common eye and ear problems, basic dental, geriatric, and palliative care, even basic trauma and emergency services. It's a fundamental shift in what your local center can potentially offer.
That's a much, much broader mandate. And the document details the population norms, too, serving about 5,000 people in rural areas for a subcenter level HWC. down to 3,000 in tougher areas like tribal, hilly, or desert regions. And for the PHC level HWCs, it's 30,000 rural or 20,000 in those other geographies.
So to support this expanded scope, and crucially to tackle that doctor availability issue across these thousands of locations, the core strategy outlined is a phased rollout of telemedicine services. This is under the National Health Mission, the NHM.
A major government health program.
Right, and using a hub-and-spoke model.
Hub and spoke, we hear that in logistics. A central point connected to many smaller points. How does that work for healthcare here?
So in this context, the HWCs, the subcenters, and PHCs, they're the spokes. They're the local points where patients actually are.
Okay.
They connect digitally to a hub. And this hub is essentially a pooled resource of doctors, MBBS docs, specialists, super specialists.
Glad
The guidelines prioritize using existing medical colleges as these hubs. Places under the National Medical College Network scheme are mentioned. I think SGP Gyms Lucknow, Amy's Bhubaneswar are listed as examples.
Okay. Established institution.
Yeah, but states do have flexibility. They can create more hubs, maybe at zonal levels. And they're even encouraged to consider a nonprofit public-private partnership model for operating them, which kind of highlights the scale, and the partnerships needed.
Okay, so HWCs are spokes, connecting to these central hubs of expertise for remote consults. Now, the document mentions a study, right, on existing telemedicine projects in India, finding they were often in silos, not interoperable. What happened with that?
Yeah, you hit on a really critical point from the document. To overcome that exact issue, that historical problem of fragmentation, and ensure standardization, seamless connectivity across the whole country, the Ministry of Health, MoHFW, decided to adopt a single standard application.
One platform for everyone.
Exactly. After auditing various existing platforms, CDEX, that's the Center for Development of Advanced Computing, their e-Sanjeevani telemedicine application was shortlisted for a pan-India rollout. The insight here is clear. A unified platform is essential for a truly interconnected system.
So eSanjeevani becomes the tech backbone for this whole thing. And the purpose of this guidelines document itself, then, is essentially acting as the national blueprint, the base document for states, for UTs, to prepare their specific proposals under the NHM scheme.
Precisely. It standardizes the application, the process, ensures interoperability through eSanjeevani, defines minimum infrastructure, helps estimate budgets, and crucially, outlines the institutional framework needed to make it sustainable.
It's the detailed manual, then, how to make this national vision actually happen on the ground.
Exactly that.
Okay, let's dig a bit deeper into how this structure plays out organizationally and physically. The sources describe a proposed three-tier architecture. Can you break that down for us?
Absolutely. Based on the document, here's how the system layers out. Level I is the HWCs. This is typically located at those medical colleges or maybe zonal levels. This is where the highest level of expertise sits.
The specialists.
Right. Specialist and super specialist consultation is provided from here. They consult with doctors at the PHCs, level 2, and they also provide direct MBBS doctor or specialist consultation to the MLHPs or CHOs, the mid-level health practitioners or community health officers, stationed way out at the health subcenters, level 3.
Okay, so hub is top tier. What's level 2?
Level 2 is the PHC, the primary health center. These places are upgraded to function as telemedicine centers themselves. So the medical officers, the MOs there, can consult with the specialists at the Hep B.
Right.
And they also provide telemedicine services down to the health subcenters, level 3, that are linked to their PHC. They're kind of an intermediary.
Got it. And level 3?
And level 3 is the health subcenter, HSC. These are the most peripheral points closest to the community. With the necessary telemedicine gear, the MLHP or CHO there can initiate a consultation. They can either go to the MO at their linked PHC.
Level 2.
Right. Or they can directly seek telemedicine services from the MBBS doctors or specialists stationed back at the Haga, level 1.
So there's a clear pathway for referral, for consultation from the most local point right up to the remote expertise.
Exactly. It's structured to enable that flow.
Makes sense. Now, who are the key people involved at each level? What are their specific roles as defined in this source material?
Yeah, the document is quite clear on the human resources and their key activities. Let's start at the hub. You've got MBBS doctors. Their role is crucial, kind of the first line of remote consultation.
Okay.
They provide initial consults to patients, usually facilitated by the MLHPs out at the subcenters. They can e-prescribe drugs, but importantly, only from an approved list that's actually available at that specific HSC. Vary. They create online clinical reports for specialists who might need to review the case later, maintain the patient's electronic health record, EHR, and they can facilitate video sessions between PHC doctors and specialists when a higher level consult is needed.
Okay. And also at the hub are the specialists.
Yes, the specialist, super specialist doctors. They are the remote experts. They provide the teleconsultation and advisory support to the MOs at PHCs and the MLHPs at HSCs. They vet reports from the MBBS docs, offer technical advice, maybe on higher-end drugs prescribed by PHCMOs, and crucially, ensure their availability according to a roster.
So they're the key remote specialists the whole system is designed to connect patients to.
Exactly. Now, moving down to level 2, the PHC, you have the medical officer, MO. Their role is multifaceted. They handle patient registration, EHR creation if the patient comes directly to the PHC. They are the primary link for consulting up with the specialists at the HUB for patients seen at their PHC. They coordinate patient flow, endorse specialist consultations, issue prescriptions based on those consults, and importantly, they provide telemedicine services down to the HSCs linked to their PHC. They act as that intermediate layer of expertise.
Okay. And finally, way out at the edge, level 3, the subcenter.
At the subcenter, you have the mid-level health practitioner, MLHP, often called the community health officer, CHO. The document really positions them as the absolute frontline facilitators. They're the ones responsible for initiating the telemedicine consultation.
Starting the call.
Yeah, either with the PHC MO or directly with the MBBS doctor at the HUB. They coordinate the patients, make them aware of specialist availability through rosters. They can directly consult specialists at the hub in emergencies or for referrals, and they dispense the drugs based on the eSanjeevani prescriptions they receive.
That MLHP role sounds absolutely central to success on the ground. They're the interface, aren't they, between the patient, the tech, and a remote doctor?
Totally. And the sources emphasize that these MLHPs need sufficient training. They have to handle the telemedicine comfortably, confidently. It even notes their specific training requirement, that certificate program in community health.
Their capability and confidence in using the tech, coordinating the interaction, sounds vital for the whole system to work at the village level.
Absolutely vital. Couldn't agree more.
Okay, let's shift gears a bit and talk about the technical heart of this system, eSanjeevani. What are some of the standout features listed in the document that make it suitable for this massive nationwide rollout?
Well, the document describes eSanjeevani as a low-cost integrated solution, some key features highlighted. It's centrally hosted, entirely web-based, and mobile compatible. That's key for accessibility, right?
Definitely.
It enables doctor-to-doctor consultation, which is critical for those referrals within the system we talked about. It has built-in video conferencing, naturally, and text chatting for real-time communication.
Standard stuff these days, but necessary.
Absolutely. It uses standard medical terminology, SNO-Med-CT as mentioned. That's important for data consistency, interoperability down the line with other health IT systems. It even supports a DICOM viewer.
DICOM, that's for medical images, right? So they can actually share and review things like X-rays or CT scans remotely through the platform.
Correct, which significantly enhances the kind of conditions you can potentially manage via telemedicine. It's not just a chat.
Okay, what else?
The platform also gives flexibility. HSCs can consult either their linked PHC or directly with the hub, offering alternative pathways. It has integrated e-prescription, and this is crucial. It has visibility into the list of drugs actually available at that specific HSC or PHC.
So the remote doctor knows what they can realistically prescribe.
Exactly. Makes the whole process much more practical. No point prescribing something the patient can't get locally.
Now, here's where the document mentions something that sounds really interesting and speaks to the depth of planning. It says eSanjeevani seamlessly captures over 12 readings from an integrated diagnostic device. What does that imply about the kind of consultation this supports?
That's a major point, yeah. It implies the platform is designed to integrate directly with point-of-care diagnostic equipment, stuff that can be deployed right there at the HWC at the spoke.
So it's not just a video call.
Not just a video call at all. It means readings like, say, Blood pressure, blood sugar, maybe even ECGs or some basic lab results can be captured automatically and fed directly into the system during the consultation.
Wow.
The insight here is that it's moving telemedicine beyond just history taking and visual inspection. It becomes a data-rich clinical interaction. It gives the remote doctor essential physiological data to inform their diagnosis, their treatment decisions. It makes remote care much more robust.
That truly sounds like a game changer for remote consultations. Anything else notable about the platform itself?
Yeah, a few other things. It features a comprehensive dashboard for monitoring performance across different levels. It allows the person at the patient end, like the MLHP, to set a preferred order for specialists at the far end.
Oh, interesting.
And it can automatically transfer a case if a preferred specialist doesn't respond within a certain time. It's also designed for integration with the ministry's My Health Record platform, PHRMS, for long-term archival of patient data. It sends SMS notifications for appointments, prescriptions, and finally, it's meant to be seamlessly integrated into the overall comprehensive primary healthcare IT application, the CPHC app. Suggests a broader vision, of a connected primary healthcare IT ecosystem.
That certainly sounds like a robust platform, really designed for scale. Now, the document also details the minimum physical infrastructure needed. At the spoke, the HWC and the hub, what does it specify there?
Right. The source lists specific minimums, trying to be practical but ensure functionality. So at the HWC, the spoke, you need a telemedicine diagnostic kit, though the specific choice is left to the state, so there's some flexibility there.
Okay.
You also need a desktop computer. Pretty standard specs mentioned Intel i5 4th gen or higher, 8 GB RAM, HD webcam, mic, Windows 10 Pro, specific ports.
The usual office setup, basically.
Pretty much, plus a printer, some miscellaneous items, and crucially, last mile connectivity. Minimum 2 Mbps bandwidth specified.
Connectivity is key.
Absolutely. And the document encourages states to use existing IT infrastructure if possible. Only propose new gear based on a gap analysis. It shows a cost-conscious approach.
Okay, so capable computer, connectivity, maybe some diagnostic tools. What about the HUD, where the doctors are?
At the hubby, the recommendations are scaled up. Initially, they suggest planning for about 100 HWCs per hubby. They recommend 6 desktops, initially 5 for the MBBS doctors, 1 for the daily specialist roster, implying multiple doctors working at once.
Makes
They also recommend employing 5 MBBS doctors per 100 HWCs initially on a contractual basis to ensure dedicated availability. For specialists, they suggest starting with 3 on a daily roster, specifically mentioning cardiology, gynecology, pediatrics as high-need areas. Those states can propose others based on local needs.
and connectivity there.
Same requirement. Minimum 2 Mbps last-mile connectivity needed at the HWB2 to handle all those simultaneous video consultations smoothly.
Okay. And the eSanjeevani application backend itself, who manages that?
So the application backend, the development, the hosting that's provided centrally by the MOHFW to all states, that standardizes the core platform. However, the states themselves are responsible for provisioning the necessary servers, database, backup, application servers, load balancers. They have options, cloud or state deployed, but they have to budget for this in their proposals.
Got it. What about training? For all these people involved, from the frontline MLHPs maybe struggling with tech to the specialists getting used to remote consults.
Yeah, that's critical. The document explicitly states that comprehensive training costs must be included in state proposals. CDAC Mohali, who developed the platform, they're working with MOHFW to prepare virtual training modules for staff at both HWCs and HUBs.
So training is built in.
It has to be.
Right.
Having the tech is one thing, right? Ensuring thousands of people are comfortable and capable using it. That's paramount for adoption, for success. The source also mentions, separately, an option for HSCs to get a specific integrated diagnostic kit costs around Rs 1 lakh, about $1,200, $1,300 maybe, if they don't have existing diagnostics. Underscores the investment needed right at the edge.
This all paints a picture of a really comprehensive plan: technology, people, physical infrastructure, training.
Yeah.
All on multiple levels. But making such a large, multi-tiered system run smoothly across a vast country like India requires super clear roles and responsibilities. Who's in charge of what, according to this document?
The source outlines pretty distinct roles. At the central level, the MOHFW provides the overall strategy. issues the national guidelines like this one, offers technical support consulting with CDAC, provides the funding under NHM, monitors nationwide usage, and shares good practices.
Setting the direction.
Exactly. Then you have CDAC Mohali. They're positioned as the central technical and support partner. They host and maintain the application, provide integration support, develop and deliver the training modules, offer hand-holding during operations, do regular updates, develop all those dashboards for the center, state, head hub, district, create a grievance redressal module, and maintain a dedicated support team for all states and UTs.
Wow, okay, so CDAC is like the essential technical and operational backbone. But it sounds like the real heavy lifting for implementation falls on the states.
Oh, it absolutely does. The state government has massive responsibilities on the ground. They have to conduct that detailed gap analysis for infrastructure in their specific context, prepare their project proposals for NHM funding based on these guidelines, adhere to the architecture and budget norms, finalize the specific HWC and HEBI locations, procure and install all the infrastructure.
That alone is huge.
It is. Plus, recruit the contractual doctors for the HEBUs, often a major challenge. Ensure adequate and consistent bandwidth everywhere. Identify and appoint nodal officers at each HWC. Conduct local training, regular operational reviews. Carry out IEC activities, information, education, communication to get the community using it. Monitor utilization data closely, adjust doctor provisioning. Identify centers that are struggling and provide targeted support. Even arrange special health melas, like health camps, based on the data coming out of the system to address specific needs.
That is a huge list. Requires significant coordination and operational capacity within each state, doesn't it?
Absolutely. It's a major undertaking for the state health missions.
And how is all of this tracked, monitored, to ensure it's actually working, delivering services?
The document describes a multi-level monitoring framework for oversight and improvement. At the national level, the Center of Health Informatics, CHI, at MO-HFW, oversees the whole system's function. They're supported by personnel from NHSRC and MAHFW, reporting up to a Director E. They develop a dashboard with KPIs, key performance indicators.
Like number of consultations, types, wait times maybe?
Exactly, things like that. And there's a national review committee with joint secretaries from NHM, eHealth, medical education, meeting regularly to review performance across states.
Okay, so national oversight based on data. What about at the state level where the action is?
At the state level, the mission director of NHM has the top administrative responsibility. They manage operations within the state, create the state's MIS based on the KPIs, and there's a dedicated project monitoring office, a PMO, set up at the state level, usually with an operations manager and an MIS expert to handle the day-to-day tracking and reporting.
Getting down closer to the ground, the district level.
At the district level, monitoring falls to the chief medical officer, the CMO. They ensure the ground-level implementation and operation in their district. The document suggests utilizing existing MIS data entry operators at the district level to help with monitoring and reporting performance up the chain to the state.
Using existing resources where possible. And finally, at the hub itself, where the doctors are.
Each hub is supposed to have a nodal officer, usually appointed by the medical college or whoever manages that hub B. This officer manages the HR, ensures doctors are available for their shifts, acts as the single point of contact, and they're assisted by a telemedicine technician for tech support and managing the hub infrastructure.
It's clear there's a carefully planned hierarchy. Responsibility and monitoring built right into the plan, aiming to track progress from the local HWC all the way up to Delhi.
You mentioned reviews. Yes, quarterly reviews are planned by the center, the state, and the district levels, focusing on both quantity, how many consults, and the quality of services. And the annual progress gets compiled, reported up through the State Health Society to the ASNMD, NHM at the center, and finally presented to the Empowered Program Committee, EPC, of NHM for review for future direction. It's meant to be a structured feedback loop.
Wow. Okay. We started this deep dive with that significant challenge getting consistent quality healthcare, especially specialist care, out to millions in rural India. And we've now journeyed through this really detailed document you provided outlining the Ayushman Bharat HWC telemedicine strategy. We've covered the why, right? Identifying those access gaps, the resource limitations making this necessary. We've explored with the vision of expanding comprehensive care at HWCs, powered by telemedicine using that hub and spoke model and the centralized e-Sanjeevani platform.
And we've really tried to deconstruct the how understanding the specific three-tier architecture, the detailed roles from the critical frontline MLHPs up to the remote super specialists, the minimum tech and infrastructure needed, and that planned multi-level monitoring framework designed to track progress and ensure accountability. This document, it truly lays out a comprehensive blueprint for a massive, massive undertaking.
You provided these guidelines, and hopefully this deep dive has given you, our listener, a much clearer, more organized picture of this ambitious initiative. Going beyond just knowing about it, to understanding the detailed what, why, and how of bringing specialist care closer to home using telemedicine in these health and wellness centers across India.
It really is about leveraging technology, but also very careful planning to extend the reach and the scope of primary healthcare, specifically targeting those rural and underserved areas that, well, need access to medical expertise most desperately.
The guidelines are incredibly detailed, aren't they? They seem to leave very little to chance in terms of the plan, the tech platform, the roles, the infrastructure specs, the monitoring. But implementing such a complex, multi-tiered system nationwide across thousands of diverse locations, it relies so heavily on factors that go beyond the lines on a blueprint. Things like ensuring consistent coordination between different levels of government, successfully training thousands of people with maybe varying technical literacy, and crucially, maintaining reliable internet bandwidth in remote, often really challenging terrains.
Absolutely.
So here's something to think about. What does it truly take beyond this meticulously crafted plan itself to bridge that healthcare gap, to ensure equitable access for everyone, everywhere? What aspects of this plan, now that we've unpacked it together, strike you as potentially the most critical dependencies, or maybe the biggest practical challenges for its real-world success on the ground? Something to consider as you look at this initiative moving forward.